Good day and welcome. Welcome to Learning Thursdays. I am Patty Corbett Ward and your host for this presentation. This is one of two presentations being released in the month of May. This particular presentation is entitled, Can We Prevent Infant Sleep-Related Deaths? What You Need to Know Now. Shortly there will be an introduction by Dr. Maggie Taylor from the Adolescent, Women, and Children's Unit at OASAS. She will present both Dr. Goodstein and Dr. Kasika. They'll be here in a moment. In the interim, I would like to provide for you a cursory overview of the Learning Thursdays educational series. A goal of Learning Thursdays is to support and help advance the educational and professional competency development of the treatment, prevention, and recovery workforce, a competency being comprised of knowledge, skills, and attitudes relative to a task. In part, we do this by offering monthly presentations that highlight content and topic areas that are current as well as relevant. As always, if you have any questions, please feel free to contact us at the Learning Thursdays mailbox. If you are interested in offering a presentation, please feel free to contact us there as well. As noted earlier, Dr. Taylor will now take over, and I will be back at the end of the presentation to say goodbye. So without further ado, Dr. Taylor, hello and thank you.
Thanks, Patty. The topic of infant-safe sleep is an important one for any organization that cares for mothers, families, and infants, but it's particularly important to those of us who work in the field of addiction treatment. A 2010 study published in the academic journal Addiction found that alcohol consumption is a risk factor for sudden infant death syndrome. A more recent 2013 study found similar results. When recent parental use of alcohol or drugs is combined with an unsafe sleeping arrangements, the risk for SIDS increases even more. There are also shared risk factors between substance use disorders and sudden infant death, such as mothers receiving late or no prenatal care and low birth weight of babies. For pregnant women who are using substances, such as alcohol or opioids, and have infants born substance exposed, there's a likelihood that these babies will be born with low birth weights, putting them at a higher risk for SIDS. The New York State Office of Alcoholism and Substance Abuse Services has about 26,000 women and 72,000 men per day in drug treatment. This is a large audience and an important one to educate on this topic. For all substance use treatment providers, learning about the topic of safe sleep and educating their staff to provide this important information to parents is an opportunity to share knowledge, to keep vulnerable infants safe, and save lives. To present this following presentation, I have the honor of introducing Dr. Michael Goodstein, an attending neonatologist from York Hospital, professor of pediatrics at Penn State University, and the medical director of research at Cribs for Kids.
Thank you, Maggie, for the kind introduction. I would like to thank at the outset OASAS and the Department of Health and Dr. Kasika for inviting me out to talk today about a very, very important topic on trying to prevent sleep-related death in infants. I am a neonatologist. I take care of premature babies and sick newborns, and this is a very important topic to me because I often get called down to my emergency department to try to resuscitate babies who have succumbed to either suffocation or SIDS, and it's a very traumatic experience for the family. It's devastating to see a baby who had been perfectly healthy just hours before, now lifeless as you try to do this resuscitation, and it's rarely, if ever, successful. So there are lots of things that we can do in our communities to help make babies safer, and that's the purpose of our topic today. I have nothing to disclose today, although I'm hoping that one day maybe I will. We have some objectives for our presentation today. We do want to improve your knowledge on treating people in shelters and families you're working with regards to how they do their infant-safe sleep practices. We want to improve your ability to feel comfortable in discussing these issues with caregivers. We want to enhance your staff's modeling of safe sleep practices so that there's a repetition that people can learn from. And we want to make sure that staff have knowledge about the Department of Health's safe sleep resources available to you to use with your clients. So infant mortality is a huge problem in the United States. The slide that we're looking at here shows the most common causes of death in infants under a year of age and compares 2005 and 2011 data. And the blue is the 2005 data, the green is the 2011. We can see that the numbers really haven't changed much in comparing these years. And the leading causes of death are congenital malformations, prematurity, and then number 3 is SIDS, and number 5 is unintentional injuries. And generally, these unintentional injuries are sleep-related deaths, suffocations, and strangulations in the bed. So when you add up the SIDS and unintentional injuries, it's almost as much as prematurity in terms of babies that are dying. Sadly, in this country, we have about 24,000 babies dying every year. And then if we kind of break this down a little bit further and we look at babies after the first month of life to the end of the first year, what we call post-neonatal mortality, far and away, as you can see on this graph in the red bar, SIDS, SUA, these unsafe sleep deaths are far and away the leading cause of deaths for these babies. And when we dig down these numbers a little bit further, we find that 3,500 babies die in the U.S. every year, suddenly and unexpectedly. And this is very tragic. When you break these numbers down even further, it's one baby dying in this country every 2 to 3 hours of every day of the year. And this is a kind of tragedy that nobody talks about. So if a teenager dies in a car accident, especially around prom time, coming up this time of year, it's all over the newspapers, the TVs, everybody talks about this, and there's lots of education done in terms of perhaps it was a driving-related incident, drinking and driving and things like that are discussed. But when a baby dies from a sleep-related death, nobody talks about this. This is something that maybe there's a small obituary on page 32 in the newspaper and there's really no explanation as to what happened. So if we don't discuss this and we don't talk about ways that we can make our community safer, these deaths are going to keep happening over and over again. Now if we take a look at some of the data in New York, we can see you're actually doing a pretty good job here. And on this slide, we're looking at these sleep-related deaths over a number of years from 2007 to 2013, and we're comparing the blue bars, which represent the U.S. as a whole, versus the dark pink bars, which is the Northeast region, and then the light pink bars, which represent New York. And you can see year by year, New York was always doing a little bit better, certainly a lot better than the U.S. as a whole, and even within the region, your numbers look very good. However, if we go a little bit further and just look at the raw numbers, what does this mean? And here we're looking at the actual numbers of babies dying from sleep-related deaths each year in the state. And you can see that we average about 120, 130, sometimes up to 150 deaths a year. And these are tragedies that we want to prevent. One thing that I'd like you to take away from this talk today is that safe sleep requires a consistent and repetitive message in our community to prevent accidental deaths. Because if the doctor says one thing, the nurse says something else, a lactation counselor says something else, a social worker says something else, we lose credibility and nobody believes what we have to say. And unfortunately what then happens is that somebody else becomes a default for new families, and that is often the grandmother. So the conversation may run something like this. A new father says to his mother, I've heard all these different things about how to get the baby to sleep. I don't know what to do. And that grandmother may very well say, well, when you were a baby, we always put babies to sleep on their tummies. And if it was good enough for you, it's good enough for my granddaughter. And in that brief conversation, we've now just doubled the chance of that baby dying of SIDS. So everybody needs to be on the same page, giving the same message. We need to dose out this response so that through repetition, people start to understand what is the safest thing for their baby, and we start to create behavior change to keep our babies safe in our communities. I'd like to start with a number of definitions. So co-sleeping is a term that we don't like to use, although it is out there and fairly popular, but it's really this vague and confusing term that tries to describe the sleeping relationship or arrangements between the infant and the parents. What we prefer is to be more specific about this and talk about either bed sharing or room sharing. And bed sharing is where any individual shares a sleep surface, whether it's a bed or another surface. They're sharing it with the infant. Some people even refer to this as surface sharing instead of bed sharing. And hopefully by the end of this talk, you'll see that that's a very dangerous thing to do. What we do recommend instead is room sharing, as you can see in the little picture on this slide, where the parent and the infant are close to each other in the same room, but they're on a separate sleep surface. And this way, you can bond with the baby, do feedings with the baby, keep the baby safe, but not put the baby at risk by sharing the sleep surface. Now, as a term that's become more popular in the literature now, that I like to explain, it's called SUID or SUDI, depending on how you arrange the lettering. And basically, this stands for sudden unexpected infant death. And this is a death that occurs in a previously healthy infant. And some of these deaths are explained and some are not. Sometimes they're very obvious. So explained examples are traumas, a drowning, and obvious suffocation. Some of these deaths will remain unexplained, such as SIDS or undetermined deaths. And these can be really hard to sort out because generally these are unobserved deaths that are occurring while the baby's in the sleep environment and other people are asleep as well. So some people refer to these now as sleep-related deaths rather than SUID. But SIDS is just a subcategory of SUID, as you'll see in the next graphic. So there are many spokes to the wheel of SUID. Some of the things are relatively rare, like poisonings and neglect or homicide. The most common causes of these deaths are in the top right quadrant of this graphic: SIDS, accidental suffocation, and unknown deaths. And what has us excited as researchers, as healthcare providers, as public health officials, is that a lot of the deaths that we thought were SIDS here turn out to be accidental suffocations. Now, why is that important? It's important because when we talk about SIDS, we're talking about risk reduction. We don't know how to prevent SIDS. However, when we're talking about accidental suffocation, accidents are preventable. We're talking about injury prevention. So if we could eliminate all the accidental suffocation and strangulation deaths, we actually drop our infant mortality rates down somewhat in this country. Now, one thing that might be a little confusing is this category unknown. And the reason that is there is because since these deaths are often unobserved, sometimes the coroner or the medical examiner may have difficulty in making a determination. Maybe it's a SIDS, maybe it's a suffocation, but they're not certain. And in that uncertainty, they decide to label it as unknown or undetermined. Now, SIDS itself has a very specific definition. The ICD-10 definition is the sudden death of an infant under a year of age, which remains unexplained after the performance of a complete post-mortem investigation. There are three components to this. There must be a complete autopsy, there must be an examination of the death scene, and there must be a review of the case history. So if a coroner in a small town hears about a death of an infant and they don't want to upset the family, and so they decide that they're just going to call it a SIDS and not do a complete investigation. That's something where the death really can't be called a SIDS because you need to have all these components done in order to make that determination that the baby has died of SIDS. Here are some facts that you should know about SIDS. Again, it's the leading cause of death for infants from 1 month to 1 year of age, which we refer to as postneonatal infant mortality. It's also a diagnosis of exclusion. You must rule out all other causes of death before you can assign the diagnosis of SIDS to that baby. The peak time of occurrence is between 1 and 4 months. You can see that on the graph in this slide, looking over month by month through the first year of life. There's this peak right in here between 1 and 4 months. What's important to note, a couple of things on this slide, 90% of these deaths will occur within the first 6 months. However, if you look, there are still deaths that occur out to 11 to 12 months. And that's important because it tells us that whatever recommendations that we talk about for safe sleep, for reducing the risk of SIDS or preventing suffocation deaths, those recommendations stay in play until the baby's first birthday. There's a higher incidence in male. It's not 1-to-1 between boy and girl babies. It's actually about a 2-to-1 ratio. It's unclear why that is. It suggests that there's some genetic component to this, X-linked, which would reflect a higher rate in males, but there's no obvious genetic link to SIDS at this time that we know of. We used to talk about seeing a big spike in the winter months, but that has kind of dissipated in recent years. It is unclear why. We like to think that we've gotten the message out to families that in the wintertime, just because it's cold outside, doesn't mean you need to put multiple layers of clothing on your baby to sleep, because overheating and overbundling is associated with a higher risk of SIDS. Now, there's a higher incidence in preterm and low birth weight infants, so those clients we need to have very special care with them. It's also associated with young mothers women who have had little or no prenatal care, and very importantly, maternal smoking with pregnancy. So we're not talking about secondhand smoke after the baby is born, we're talking about during the pregnancy. And this is really important because if mothers didn't smoke during pregnancy, we estimate that about a third of SIDS cases wouldn't happen. So there are chemicals in the smoke, nicotine and other chemicals, that impact the development of the baby's brainstem that make them more vulnerable to a SIDS event. Unfortunately, we also see racial and ethnic disparities when it comes to SIDS. It's twice as common in the African American population. It's 3 times as common in American Indian and Alaska Native babies. There are some explanations for this, although we don't know everything for why this happens. We do know some of the reasons. For example, in the African American population, mothers are less likely to breastfeed their babies, and breastfeeding is protective against SIDS. In the African American population, mothers are more likely to share the bed with their babies, and that's a risk factor. Additionally, in the African American population, mothers are more likely to put their babies face down or prone to sleep, and that doubles the risk of SIDS. For the American Indian and Alaska Native children, there are high rates of cigarette use, alcohol use, and drug use. And there's also high rates of bed sharing. And when you have bed sharing in an environment where a parent might be impaired, the risk of SIDS increases dramatically. Now, though we don't know what the cause of SIDS is, we do have a model to try to explain it, as is seen in this slide is the triple risk model. As one would expect in talking about the triple risk, there are 3 components to it, and where these circles intersect is where the baby is most vulnerable to a SIDS death. So we'll talk briefly about each of these circles. If we look at the bottom left in this turquoise colored circle, we have the vulnerable infant. There's something different about this baby that puts them at risk. For a small number of these babies, it may be that they have a cardiac abnormality, so they get a sudden abnormal rhythm of the heart that leads to the heart stopping. This may represent 5 to 10% of SIDS deaths. The majority of the deaths that are truly SIDS deaths are felt to be related to having a brainstem abnormality. And although we don't have time to go into details about all the findings that make us believe this, we do know that there are serotonin abnormalities in certain areas of the brainstem that are important in what's called the autonomic nervous system. And part of that nervous system involves the arousal from sleep. And that if there's a defect in that, if babies get into too deep of a sleep, they can start to have autonomic abnormalities in their heart rate and breathing, and if they don't arouse or wake themselves up, they can lead into a situation where they will stop breathing, lead to a coma, and eventually a SIDS death. Now, the difficulty with this vulnerable infant idea is that we have no tests out there to identify who's the baby who's vulnerable at risk. So when we look at this, we have to provide safe sleep education information for all families. Now, in addition to the vulnerable infant, the second circle, the orange one on top, is a critical period of development. So 90% of SIDS deaths occur during the first 6 months of life. This is a period of fantastic change that's going on in the baby's brain and their muscular development. They're learning how to control and move the head and neck. Their sleep patterns are changing significantly over time. So this is a vulnerable period. Children don't die of SIDS when they're 2, 3, or 4 years of age. It happens during the first year and typically during the first 6 months of life. Now, the third part of this triple risk model is this dark blue circle, the exogenous stressors, or what some people refer to as extrinsic risk factors. And typically what we're talking about here is the environment. And this is where we really focus our education efforts, because we can't pick out the vulnerable infant. We can't do anything about the baby growing up through the first year of life, but we can impact the environment. And some of these environmental factors include the baby's sleep position, whether they're sleeping on their back or on their tummies, what kind of bedding the family is using, whether the baby's being overbundled, whether the room is too warm, and whether they're bed sharing, and especially bed sharing in light of smoking or alcohol or drug use. Now, when we talk about the recommendations in terms of promoting safe sleep and reducing the risk of SIDS, we have these recommendations are based on evidence. And we label these different recommendations on the strength of what we call the strength recommendation taxonomy, or SORT. And so as I talk about these recommendations, they break down into level A, level B, and level C recommendations. For level A recommendations, there's good quality patient-oriented evidence that pushes us to make the recommendation. Level B is where there's only inconsistent or limited quality of the patient-oriented evidence. And then level C recommendations are based basically on consensus, on expert opinion, where there really just isn't a lot of good, solid science behind the decision to make the recommendation. Basically, our recommendations are designed to reduce the risk of SIDS and sleep-related suffocation, asphyxia, and entrapment deaths. And again, all these recommendations stay in place until the baby's first birthday. And the reason that we use the first birthday is that the studies are done on epidemiology. Basically, people go out and do death scene investigations, and they compare the scenes to the babies, the environments that the babies had died in, to healthy babies who survived and did not succumb to SIDS. And they look for differences in these environments and the cares that were provided to the children. And so when these studies are done, it's typically done for up to the first year of life. So because the studies go up to 1 year, the recommendations are made until the first birthday. Now, some people talk about the fact that recommendations change over time, and that's true. And you think about it, that makes sense. We always want to use the best science and evidence that's out there. And when we think about this, you know, you have cell phones and people don't use their Samsung One or their iPhone 2, you know, they're using the latest technology. So as we learn more and more about safe sleep and we get new studies coming out, we want to share with people the best evidence so that they can use that evidence as either the providers talking to families or families themselves in terms of making the best decisions for their children and keeping them safe in the home. So here's one example. The first recommendation for back to sleep came out in 1992, where the AAP said babies shouldn't be put on their tummies or prone, they should be put on their back or side to reduce the risk of SIDS. But this evolved over time. So in 2000, we said the back is preferred, but the side is better than prone. And then by 2005, we changed it to be just the back only. Now, why did this happen? What happened was studies started coming out showing that there was a risk to side positioning. And a number of studies showed that the side position put the infant for as much risk of dying of SIDS as if they were laying on their tummy. And it showed a risk of about two times the risk compared to being on the back. And it's about the same equivalent to if you were laying on the tummy. And the reason that we didn't know about this, because before this period of time where we made the initial recommendation, babies typically slept on their tummy. And it wasn't until recommendations came out that more babies started sleeping on their side, and we started seeing the impact of that recommendation. So when babies are on their side, it's kind of an unstable position, and then they tend to roll over face down. And babies that are not used to sleeping face down have an especially high risk of dying of SIDS. So this is something that's very important to note if you're dealing with grandparents. If the parents are keeping the baby on the back and then a grandparent decides to babysit and they put the baby face down, the risk of death increases dramatically up to 20-fold. Now, for better or worse, change is messy. So the recommendations become more nuanced. So it used to be a really simple message, back to sleep. That was a message that started in 1994. And now the recommendation or the campaign is called Safe to Sleep. And safe to sleep is more than just being on the back. So it's not just sleep position, it's also about the sleep location. It's about what kind of bedding you're using. It's about not smoking. It's about breastfeeding and other recommendations that we're going to talk about. So it's a lot more difficult to get all this information to parents. So I'm going to review the recommendations, and then we're going to go dive in a little bit deeper into some of the recommendations, some of the controversies that surround some of the recommendations, and try to give you information that you can use with your clients in terms of explaining things so they can understand what's necessary for behavior change. So these are the A-level recommendations that have good, solid, patient-oriented evidence behind them. So babies should sleep on the back for every sleep event. Some people get confused and think that back to sleep is just when they put their babies to sleep at night, and it doesn't count for nap time. So every time a baby goes to sleep until they reach their first birthday, they should be sleeping on the back. You should always use a firm sleep surface. Soft surfaces are dangerous for babies. Room sharing is recommended. So the infant should be on a separate sleep surface, but close to the parents, but not sharing the bed. We want to keep soft objects and loose bedding out of the crib. We want to avoid smoke exposure, not just during pregnancy, but also after birth. That's secondhand smoke. And by the same token, we don't want parents with any alcohol or illicit drug use during pregnancy or after birth. Additional level A recommendations include avoid overheating your baby, Do not use home cardiorespiratory monitors as a strategy for reducing the risk of SIDS. And that healthcare professionals, whether they're in the nursery or in the NICU or child care providers, should endorse the SIDS risk reduction recommendations immediately from birth. And that media manufacturers should follow safe sleep guidelines in their messaging and advertising. Okay, there are just a couple of level B recommendations. One of them is to avoid commercial devices that are inconsistent with safe sleep recommendations. And another is that we should provide supervised tummy time for babies. So babies can't stay on their back all the time. They'll get flattening of the head, or what we call positional plagiocephaly. In order to avoid that, babies need to have some time off the back of the head. And when you're doing that, that means having them prone, but it means that they need to be supervised, and it's while they're awake. So it doesn't mean putting them on their tummy and then walking into another room to make a sandwich or have lunch. Because if the baby falls asleep, then what you have is a baby sleeping prone, which dramatically increases their risk of death. There are a couple of level C recommendations. One is that we continue with ongoing research and surveillance, looking at these risk factors and causes, so that eventually we can figure out everything that's going on in terms of why these deaths happen, with the ultimate goal of eliminating all these deaths in our communities. And the other level C recommendation is there's no evidence to recommend swaddling as a strategy to reduce the risk of SIDS. So again, we need to move from just the basic message of back to sleep, because here's a baby sleeping on the back, and here's another baby sleeping on the back. And if you could see within this mess of all this stuff in the crib, right there is the baby's face. So although this baby is on the back, that's not a safe sleep environment. So we have to really give parents all this information to make sure their babies are minimizing risk and staying as safe as possible. And I'm going to spend a couple of minutes now reviewing some of the data that supports the reasoning behind our recommendations. So this is from our neighbors a little bit south of us down in Allegheny County in Pennsylvania. And their coroner's office collected data on these deaths over a 6-year period. And you can see from this slide there are almost 90 deaths, and almost 90% of the babies were found in an unsafe sleep environment. So a lot of this really reflects back to the environment the baby's sleeping in. And again, if we look a little bit to our neighbors down in New Jersey, there's data from Barbara Osfeld in the New Jersey SIDS Center that looked at the number of risk factors in the environment that were involved with these deaths, and found on average 2 to 3 risk factors for any of these deaths. As a matter of fact, less than 5% of the cases had no risk factors. So we got to hammer away at families that they keep that environment safe for their babies. Okay, bed sharing is particularly dangerous, and I'm just going to go through some data. This is a study from the Chicago Infant Mortality Study. And one of the things that they found was soft bedding was really dangerous, and that increased the risk of SIDS 5 times. As I already mentioned, sleeping on the stomach pretty much doubles the risk of dying of SIDS. Another thing that came out of that study is that SIDS victims were over 5 times more likely to have shared a bed with other children. So the idea of a family bed is not a good idea. It's actually a very dangerous thing. Now, I don't know if any of you have ever had a toddler sleeping in bed with you, but it's like having your own personal tornado in bed. They have no idea or concept of your personal space. And it's very easy for a small child to roll over onto a baby brother or sister and unfortunately block their airway or make it so they can't breathe, and the baby can succumb to a suffocation or SIDS event. Okay, and then some of these things just don't add up, they start to multiply. So if you sleep on the stomach on soft bedding, it increases the risk 21-fold. Okay, here are some pictures that give good examples of what a safe sleep environment looks like. So the picture on the left shows the crib. There's nothing in it but the baby, a firm mattress that meets to the edge of the crib. There's nothing loose in there, no crib bumpers. Crib bumpers are not recommended. Now, although this picture is really pretty good, the picture on the right is even better. Why is that? Because we're actually showing the room sharing where the mother's in close contact with her baby to facilitate breastfeeding and monitoring the cares of her baby. And that's really an ideal photo or image of how it should look when we're creating a safe sleep environment. So when we talk about babies sleeping on their tummy, because parents will often say, I have some problem getting the baby to sleep on the back, and people tell me the baby will sleep better on the tummy. And to some extent there is some truth to that, because babies who are put on their tummies to sleep will have these longer periods of deep sleep. But there are problems with that because it's harder to wake them up from their sleep. They experience less movement. They're less reactive to noises in the environment. and they can experience sudden drops in their blood pressure and loss of heart rate control that can lead to a SIDS-like event. So I actually tell parents that, yeah, sleeping on their tummy increases the amount of sleep, but some of these babies are going to sleep themselves to death, and that's obviously something that we don't want to have happen. So a lot of parents fear putting their babies on their back because of the idea that their baby might spit up and choke to death. So I want to spend a couple of minutes using a little slide to show through anatomy and physics why parents and all of us don't need to be fearful of this, that babies are not going to aspirate and choke to death. So if we look at the baby with the cutaway on the left, we can see the orientation of the airway or trachea is higher than where the esophagus is. So if this baby were to spit up, and I always tell parents if they're afraid of the baby spitting up, to put the baby on the back and lean the head to the side a little bit. So when they spit up, most of what's going to come out is going to come out of their mouth and dribble down the side of their face. But anything that goes back down the mouth through the force of gravity is going to go into the back of the throat, into the esophagus or the feeding tube, and head back down toward the stomach. Okay. Now let's look at the baby on the right who's sleeping in the prone or tummy position. This baby is less likely to wake up to a threat in the environment. Now what happens when this baby spits up? Now most of what comes out is going to come out of the mouth, but anything that sits in the back of the throat, by gravity, the lowest point is the airway. And so which baby in these pictures is more likely to have something get into their airway and possibly into their lungs? It's actually the baby who's laying on the tummy, not the one that's laying on the back. And the data support this idea. So in looking at this graphic here, we're looking at the rate of SIDS in the United States over a period of about 20 years, starting in the late 1980s. And the yellow bars represent the rates of SIDS year by year before the AAP came out with the recommendation for back sleeping in 1992. The blue bars represent the time change when we were moving towards back sleeping but did not have the back to sleep campaign yet. It was 94 where the back to sleep campaign started. And what you can see here is this dramatic drop in the rate of SIDS over this period of time. And if you look at this green line that's traveling up, that's the rate of babies who are exclusively sleeping on their back as reported by their parents in this country. So as more babies sleep on the back, the number of SIDS deaths goes down. As a matter of fact, over a 10-year period, this represented a 52% drop in the number of babies dying of SIDS in this country. This is one of the greatest public health success stories of the late 20th century. A simple educational message, which really didn't cost very much money to get out there, saved thousands and thousands of lives. When we really look at this as an aggregate, there are about 50,000 people walking around alive today who don't even know it because they were put to sleep on their back by their parents and didn't die of SIDS. And during this period of time, another important thing to note here is that we didn't have this dramatic increase in the number of babies being admitted to hospitals for pneumonias from aspiration or dying of aspirations. There was no increase at all from this. So basically, back sleeping saved a lot of lives without making babies sick from aspirating. And as we talk more about aspiration and sleep position, again, a lot of people complain or they're fearful that if their babies spit up and have reflux, that they're worried about putting their babies to back on the sleep. And the truth of the matter is that unless the baby has so much reflux that the risk of their death from reflux is greater than the risk of SIDS, then babies should still be kept on their back to sleep. And that's the recommendation of the American Academy of Pediatrics as well as the North American Society of Pediatric Gastroenterologists and Hepatologists. So basically, supine position does not increase the risk of choking or aspiration in infants with reflux. Part of the reason is that we have protective airway mechanisms. So while you're watching, if you're having a sip of a coffee, a tea, a soda, a glass of water, whatever it is you have with you, and just a little bit of that goes down the wrong pipe, down into your airway, what happens? You're going to start coughing. And it's not just a polite Queen's cough. You start coughing violently to the point where maybe somebody's saying, Annie, Annie, are you choking? Do we need to resuscitate you? Very embarrassing when you're in a movie theater and you do this. So we have these very strong protective reflexes that keep a lot of liquid from getting down into our lungs, causing us to aspirate and make our lungs sick with pneumonia. Babies who are neurologically intact have the exact same reflexes. So we don't need to worry about reflux. Babies will be fine sleeping on their back. They will protect their airways if they should spit up. Okay, so there's no reason to elevate the head of the infant's crib. It is not effective at reducing the amount of reflux that the baby is having, And babies can accidentally roll down that incline and end up face down or into some sort of bedding that could compromise their breathing and put them at greater risk of dying. Okay, so when we talk about infant sleep location, again, infants should sleep in the parent's room, close to the parent's bed, but on a separate sleep surface that is designed for infants. Ideally, you should do this for at least the first ideally you should do this for the first year of life, but at least for the first 6 months at the minimum. Again, 90% of those SIDS deaths occur in the first 6 months, but again, because there are some deaths that occur after the first year, we do recommend out to a year, but certainly if that's a struggle, 6 months would be the minimum that we ask for. Okay, and where does this information come from? Well, it comes from data, and this is from a study done by James Kemp at the University of Washington in St. Louis, looking at infants under 8 months of age and their risk of death in a crib versus the adult bed. And what they found was that there was 6.3 deaths per million infants who were found in the crib versus 255 deaths in these infants who are found in the adult bed. That's a 40-fold increase in terms of the risk of death, not a 40%, but a 40 times increased risk of death by sharing the bed. So what they concluded in their study was the risk of SIDS was greatest if you shared a sleep surface. It was intermediate if the baby was kept in another room, and the risk was least if the infant was in the same room without bed sharing. And there are other studies that have looked at this. A more recent study, the New Zealand SUDI study, looked at this, and they kind of flipped it around. Instead of the risk of death from bed sharing, they looked at it as how protective was room sharing. And they found what's called the adjusted odds ratio, or a hazard risk of only 0.36, which when you translate that into percentages is a 64% protective effect from room sharing against SIDS. So when you look at the task force statement, we estimate a 50% risk reduction. It's really a very conservative estimate. Now, some people will ask, how many months do we need to do this for? Unfortunately, these studies didn't break it down month by month by month. I mentioned that 6-month kind of watershed mark where 90% of the deaths occur. But since there are deaths that occur out to the end of the first year, we don't have a way to say when you can kind of cut back on that. So ideally, it's for the first year, but again, 90% of the deaths are going to occur in the first 6 months. Okay, now some people have asked, why is room sharing protective? What's the benefit for doing that? And we don't really completely understand that, but we do have some ideas as to why it might be protective. So if we think of SIDS as an ultimate failure of the baby to arouse from too deep of a sleep, where they get to the point where they just stop breathing and then they don't kind of resuscitate themselves, so they need to have some arousals from sleep. And if you're interacting with the parents because they're close by, there are more small awakenings during the night. And these they might even fully awake, but these little stirrings or movements take them out of a deeper sleep that may be protective against SIDS. Additionally, to these small awakenings, room sharing increases the likelihood that a mom's going to be breastfeeding. And we know that breastfeeding is a very strong protective effect against SIDS. So not only do we want to encourage moms to breastfeed after they give birth, we want to start doing this during their prenatal care, so that there's really like a dose-response effect. The more breast milk a baby gets, the more protection they get against SIDS. So if we can get moms focusing in on their breastfeeding early on, that's a great thing for us to be focusing on. Okay, now also related to feedings, what do we do at nighttime? Because people do fall asleep sometimes. And so the question, well, what do I do if I'm sleepy? Because what happened in our last statement in 2011, we said not to put the baby in bed with you to feed. And what some people started doing was trying to get up and put the baby on the couch with them or in a recliner. And they would fall asleep on the couch or the recliner, and it turns out that's an extremely, extremely dangerous place for a baby to be put to sleep. And the risk of death can be up to a 40-fold increased risk. So in the latest statement that came out at the end of 2016, we acknowledge, sometimes parents do fall asleep unintentionally while they're feeding their baby. So rather than do it on a sofa or a couch, we'd rather that you do your feeding on the bed, preferably kind of propping yourself up so you're less likely to fall asleep. But you want to remove hazards from that sleep area in case you do fall asleep. So you don't want any pillows, sheets, blankets, other items that could obstruct your baby's breathing or cause overheating while you're in bed if you should fall asleep with your baby. Also, once you wake up, we want to make sure that the baby doesn't stay in bed all night long, because we know the longer the baby spends in bed, the more time the baby spends in bed, the higher that risk goes for the baby. So as soon as you do wake up, if you should fall asleep, that baby should move back to that safe sleeping spot as soon as possible. Okay, and again, couches, sofas, cushioned armchairs, super, super dangerous. Babies should never sleep alone or with anybody on these surfaces. It is one of the most dangerous places they can be. Again, these odds ratios or hazard risks are anywhere from 5 times to over 65 times the risk of death. So we never ever want to see babies on those environments for sleeping. Now, we talk about bed sharing as being dangerous. There are particular instances of bed sharing that are very, very much higher dangerous than even if you try to avoid some of these hazards in the bed. And we can break those down into risks of the baby. So babies who are under babies who are under 4 months of age, babies who are premature or low birth weight, or babies that were exposed to smoke during the pregnancy. So those are super high risk where you really want to avoid the bed sharing. Then there's the person who may be in the bed with the baby. So if that bed share is a current smoker, that greatly increases the risk of a bad outcome for the baby. If that bed sharer is using any kind of medication or substance that could impair their alertness or arousal, that really increases the risk. And then somebody who's sharing the bed who is not one of the parents. And again, that includes other children, as we saw in that other slide. And then there's just issues with the surface itself. So particularly soft surfaces are dangerous, waterbed, couches, armchairs, and then other things that are in that environment, the pillows, quilts, and comforters, greatly increase the risk for the baby. Okay, now as much as I can sit and talk to you about why it is dangerous to share the bed, I think a picture truly is worth 1,000 words in this case. So I want to go through some images so that you can get an idea of why these babies are at risk and what happens to them when they get into these compromising situations. So we're going to look at some pictures. We used some dolls for these pictures. I just want to say right up front that none of the dolls were harmed in the filming of these images. So we kept them safe. So here's a mother sleeping with her baby. And when we go to sleep, we just don't lie in one position the whole time. We move around. And when we do, what can very easily happen is this kind of situation. And now if we look at this image, the baby is now face down, which doubles the risk. The baby's in soft bedding. And when you combine those things, we have a 20-fold increased risk of the baby dying. And then look where the mom's arm is. There's enough weight in a human arm to suffocate a newborn infant. And that's all that it takes. So this idea of bed sharing is a really, really dangerous idea. Now, a lot of times, we see 2 parents in the bed with the baby. And for those people who are advocates of bed sharing, they'll tell you to reduce risk that the baby should never be in between the parents and become a baby sandwich. The baby should be laying out to the side. But honestly, what parents often do is put the baby in between. Now, parents will say, I'm always aware of my baby even when I'm asleep. But the truth of the matter is, just from the physiology of sleep, when you reach a certain level of sleep, you're unconscious and you're not aware of your surroundings anymore. And I think parents really recognize that to some extent, because they'll, rather than put the baby on the outside where it would be less dangerous, they put them in the middle. They don't want to put the baby at the outside because they're afraid the baby's going to roll off the bed because they're not going to be aware when they get into too deep of a sleep. But what can happen to this baby laying in between the parents? So if we look at the next slide, and I'm just going to toggle back and forth so you can see what happens. It just takes a little bit of movement from one of the parent to get too close to their baby. And when we look at this close up, it doesn't matter whether the parent is over the baby's chest to the point of crushing or asphyxiating the chest so the baby can no longer take a breath, or just the nose and mouth get occluded by the sleepwear or the pressure over the nose and mouth so that they can't take a breath that way. Either way, the result is the same. The baby's going to suffocate. A lot of times we can see what has happened when we do good death scene investigation. The investigator will ask to see what the parent's bed clothing was when they went to sleep that night. And right around the time of death, there's something called effluence, or the release of these bloody secretions from the nose and mouth through the lungs around the time of death. And you can pair up what the parent was wearing with where they were laying and where the baby was found to see that there was some sort of suffocation event that occurred. And that is a very tragic thing when parents realize what has happened. Again, couch sleeping is super dangerous. So parents like to lay with their babies on top of them. And what they typically do is lean the baby in towards the couch cushion, because again, they recognize that when they fall asleep, that they might relax and get into too deep of a sleep and let go of the baby, and they don't want the baby to tumble onto the floor and hit their head on a coffee table. So they lean the baby into the couch cushion. And then what happens is the baby can work its way down and get wedged in to the cushion. And it doesn't matter whether the nose and mouth are against the parent or against the cushion. Either direction, it doesn't matter. If they get wedged in there tight enough, they're not going to be able to breathe, or the nose and mouth get occluded and they're not going to be able to take a breath, and they're going to have a suffocation kind of death. Okay? Children in adult beds are also dangerous. The biggest part of a baby is the head. So if there's a little bit of gap, and it doesn't matter, you can see in this picture, here's a headboard, here's a gap between the wall. If they slip down, the part that's going to get entrapped is the neck and the head. And that can lead to strangulation, entrapment, death. Okay. We also want to keep soft objects and loose bedding out of the baby's sleep environment. Again, all these things, if the baby gets their face up against them, they can get into trouble with that. So they can have entrapment, strangulation because of pillows, quilts, comforters, sheepskins, and bumpers. And again, loose beddings, blankets, sheets, and these are all dangerous for the baby. So instead of having things bundling and wrapping the baby up, we recommend that you use good infant sleep clothing instead to keep the baby warm and avoid those kind of dangers. Okay. Again, another simulated construction. Positioners used to be popular for a while to try to keep babies on their side, but we know that the side is an unstable position, and positioners are no longer really on the market for this purpose. The FDA banned them. People can still buy them for other purposes, but we don't recommend them because if they slip down, the baby becomes face first, and this is a significant danger for suffocation death. Okay, again, the same idea with pillows and soft bedding. If the baby gets their face and they sink into the soft bedding and they're not strong enough to lift or turn their head, or they get into such a deep sleep that they don't want to lift or turn their heads, they can get into significant danger very quickly with this. And we've looked at this over time in terms of soft bedding and what parents are doing. And this is data from the National Infant Sleep Position Study, which took place over an almost 20-year period. And what we're looking at is years across the x-axis here over time, and on the y-axis is the percentage of families who are using soft bedding in their baby sleep environment. And what we see here is that there's been a decrease, and these different lines represent different ethnicities, and the overall grouping for all U.S. babies in this study were the lines that have the X's through them, which you can see running through here. At the beginning of the study, 86.5% of parents that were in the study said they used soft bedding with their baby. And that's decreased over time. However, if you look at this, the rate of decline is really greatest in the first decade. In the last 10 years of the study, there's very little decline. Also, very concerning is that teen mothers showed no decline. At the end of this study, about 85% of teen mothers were still using soft bedding to quote-unquote protect their babies. Now, there are some other predictors of having an increased risk in terms of populations. And those, again, are the young mothers, women who are non-white in race and ethnicity, and those mothers with less than a college education. So very concerning things to focus on in your population that you're dealing with: young mothers, African-American mothers, low-educated mothers who are going to be more likely to use the soft bedding and may need extra education regarding this issue. Now, people have their reasoning for using soft bedding, one of which is for comfort and warmth, and they actually extrapolate what they think will feel good for them, but is actually dangerous for their baby. So they're thinking, I like to be snuggled up, all kinds of soft, warm things around me, without realizing that these soft things are a danger to the baby, that all this bedding, if it gets around the nose and mouth and head, create an extreme risk for the baby. They also mistake the idea that if they pull the sheet tight, that it's taut, that that is the equivalent to being hard or firm mattress, and that is not the case. You can have a very tight-fitting sheet, but if you put a pillow or something soft under there, the baby will still sink into it and be at risk. The other reason that people use soft bedding is that they mistakenly think they're providing a safe environment for their baby. So if you look at this image here, what somebody has done is put their baby for a nap on the adult bed and then surround it with pillows so the baby won't roll off the bed. Unfortunately, what can happen is the baby can scoot into the pillows and soft bedding, and then if they can't back out of it and just kind of keep moving forward into it, they can get their nose and mouth obstructed and create a high-risk situation for suffocation. And then for older infants, parents, even though if they recognize soft bedding as a risk, as the baby gets older, they start thinking that their baby is less at risk. So they develop some complacency as the baby gets older. However, there's a study that came out just a couple of years ago that showed that soft bedding is the most important risk factor for infants between 4 and 12 months of age. Infants, again, can roll into the bedding and then cannot seem to unroll or get themselves out of that dangerous situation. Let's take a moment now to talk about bumper pads. In 2011, the AAP came out with a recommendation to no longer use bumper pads. Before 2011, it was to not use soft pillow-like bumper pads, but we started seeing deaths of bumper pads regardless of how they were designed. Now, even before we came out with the recommendation in 2011, in Chicago, they banned the use of crib bumpers because they had seen deaths. Since that recommendation came out in 2011, the state of Maryland and more recently the state of Ohio have banned the sale of bumper pads in the baby sets. So the original intent of bumper pads, why do we have them in the first place? Well, we used to have them, if we look at these images here on the left of this slide, the slats were really wide. And babies' heads could slip out between the slats. And again, the biggest part of the baby is that, so actually what happens, their bodies would slip out, their heads would get entrapped, and they would strangle and suffocate on the rails. So people developed crib bumpers as a way to prevent that from happening. But then they came up with a better idea. Let's make the slats and the crib closer together so a baby can't slip out between that. And the current standard is 2 3/8 inches or less from slat to slat. If you don't have a ruler to see if a particular crib is safe, you can see from this picture here, a soda can standing on the vertical should not be able to slip through that. It's also the same width as that of a dollar bill. So a crib that's up to manufacturing standards should have slats no greater than 2 3/8 inches. Now, with these new cribs, there's no way a baby can slip out, so it really eliminates the purpose of the crib bumper, so we don't need them. And the concern with the crib bumpers is that we started seeing fatalities. And a study was done by Brad Thatch, another researcher at the University of Washington, St. Louis, who took Consumer Product Safety Commission data. And he found 3 mechanisms for deaths related to bumper pads. One was, as we had described initially, these pillow-like soft bumpers where the babies got their faces into them and couldn't get them out and suffocated. Another was entrapment, the baby's getting caught between the mattress and the crib and these firm bumper pads. And then the third way was strangulation from long bumper ties getting wrapped around the baby's neck. Now, we don't see those bumper tie issues anymore because the ties are made shorter, but these other 2 mechanisms of fatality can still occur. Now, what we've recommended is no bumpers in the crib, and we looked at why people still use them. They're worried about injuries, and what Dr. Thatch saw in his study, again looking through the consumer product data, is that there were only very minor injuries that were possibly prevented by the bumper pads. So when you weigh the risk of a death, strangulation, suffocation versus a bruise or a leg getting entrapped and having to be pulled out, really there's no comparison between the 2. I just want to focus on this image for 1 second. This is a picture that was given to me by a healthcare provider after I'd given a lecture a few years ago. She put her baby down to sleep, and she had the crib bumpers, and she forgot something in the room. It was maybe 10-15 minutes, and she put them down, and this is what she found when she went back in the room. Now, this woman and her baby were quite lucky because you see the way this crib bumper is wrapped around the baby, it's around the torso. If that had gone up around the baby's face, the nose and mouth, she wouldn't have been taking pictures of this to show me. She would have been resuscitating her baby. So it doesn't take very much to get into a dangerous situation. So we do not recommend bumpers in the crib. There's no evidence that these pads or other products that are similar that attach to the slats or sides prevent significant injury in young infants. Because of the potential for suffocation, entrapment, and strangulation, we don't recommend any of these products. Another question that comes up that we should talk about for a few minutes is swaddling and whether or not that's a good or safe thing to do. So there are benefits and downsides to swaddling babies. And it's been around for thousands of years for particular purposes, mostly to keep babies warm and to kind of keep them from fussing too much. So definitely it's been shown that swaddling will calm infants, and it does promote their sleep. It will decrease the number of awakenings, and if babies are swaddled up, parents are more likely to put them on their backs. You're not going to wrap up somebody so they can't move their arms and put them face down and put them at risk. However, there are some downsides to swaddling, and they're listed here. I won't go through everything here on this slide, but it can increase the baby's respiratory rate. If babies are swaddled too tightly and kind of mummified in the swaddle so they can't move their legs around, it can promote an abnormality in the hip, what's called hip dysplasia, so the hips don't develop properly in the socket, and that creates significant problems when babies get older and are trying to walk. When you do swaddling, there's a real art to swaddling properly, and my nurses are great. I'm pretty good at it after all the years I've been doing, taking care of babies, but our nurses, it's like baby origami the way they do it. So they know how to do a good swaddle. Not every parent can do a good swaddle. If that swaddle gets loose, then it becomes loose bedding. And if that loose bedding gets up over the baby's nose and mouth, then that can create a significant problem. So there are lots of issues with why maybe swaddling is something that we don't want to do. What I can tell you is that there's insufficient evidence to recommend swaddling as a strategy to reduce the risk of SIDS. And if parents decide to do swaddling, they have to do it correctly to avoid the possible hazards that we were just talking about in the last slide. And swaddling does not eliminate the need to follow all the other safe sleep practices that we're talking about today. Now, in the last couple of years, there have been 2 studies that came out that have further questioned whether people should do swaddling or not. One is listed here by McDonald in the Journal of Pediatrics. And this was a review of data from the Consumer Product Safety Commission about deaths related to swaddling, whether it was a swaddling blanket, a special swaddling blanket, or just a regular blanket. So they looked at each of these, wearable blankets and regular blankets. And what they found was with the wearable blankets, they reviewed 10 deaths. But it wasn't just that the babies were being swaddled. Over 3/4 of the babies were diagnosed as having what we call positional asphyxia. They were found sleeping face down. And almost 3/4 of the babies had additional risk factors. For the babies that were in regular blankets, over half of them were, again, diagnosed with positional asphyxia. They were found sleeping face down, and over 90% of these babies had additional risk factors. So it's unclear from this article whether swaddling is really the problem or whether it's a lot of other things going on in the sleep environment that are dangerous in addition to the swaddling. Now, another article came out a year or 2 later. This is 2016 by Peace in Pediatrics. And I don't know how they got this doggy swaddled, but man, they did a really good job doing that. So I was pretty impressed by that. But in this article, they did something called a meta-analysis. And so they pulled a number of studies together and then looked at the total results. And what they found was a slight increased risk of SIDS if babies were swaddled. However, if you break it down by the baby sleep position, some really interesting phenomena come out of this. One is if the baby is prone, that risk of death is almost a 13-fold increased risk. Okay? And again, that kind of makes sense. If you're face down and you can't move, you really could get into trouble if you can't get your head turned out of a compromising position where you start rebreathing the same air and start losing oxygen. The side position also had an increased risk, and almost slightly over 3-fold increased risk with swaddling in the side position. But in the supine position, it was less than a doubled risk. So swaddling is concerning, but it really depends in part on how you place the baby down to sleep. And also what they found was that depending on the age of the baby, especially beyond 6 months of age, seemed to be the period of greatest risk for swaddling and adverse outcomes. Now, this study had some significant limitations to it. Some of the data they looked at was over 30 years old. There were differences between how some of the studies were conducted, and most importantly, there was no consistent definition of what swaddling was. So this study is not the be-all and end-all in terms of what we recommend in terms of swaddling. What we do recommend, and this is taken right off the American Academy of Pediatrics website for families called healthychildren.org, is that if you do wrap a baby or swaddle them to calm a fussy baby, you should make sure that the baby is sleeping on the back and that you should stop your swaddling when the baby starts to roll over so you don't have them face down and swaddled. Okay, we'll talk now about pacifiers. This is very interesting. So a number of studies have been done that show that when babies are offered a pacifier at their nap time and bedtime, and it's done consistently, it significantly reduces the risk of SIDS. We don't know what the mechanism is, because we know that babies don't keep pacifiers in their mouths all night long when they fall asleep. Usually within 15 to 60 minutes, they fall out. Some people suggest that it might have to do with decreasing the arousal threshold so they wake up more frequently so they don't get into that super deep sleep that puts them at risk. All I know is that when my son was a baby, we put about 60 pacifiers in his crib so that when he'd wake up, he'd be able to find one again. He probably had the lumpiest crib ever. I don't know how he ever got to sleep in the first place, but I didn't have to get up and keep giving him another pacifier. Now, there have been some concerns expressed about the use of pacifiers, especially if you're looking at baby-friendly hospitals and the promotion of breastfeeding. So some early studies came out that showed an association with giving a pacifier and decrease in breastfeeding time. But it turned out that those were just observational studies, which are kind of the weakest form of data that we collect. It doesn't really tell us why something is happening. And what it turned out was, it wasn't the pacifiers being administered that was causing babies to not breastfeed as much. What really was happening is mothers were offering pacifiers because they were having trouble breastfeeding their babies. So it wasn't the cause, it was a consequence. When well-designed trials were done to really look at what was happening, they found no association, either term or preterm babies, regarding the use of pacifier and the length of period a mother decided to breastfeed her baby. There have been multiple studies looking at this. Of all the studies, only one found a slightly decrease in breastfeeding duration at a month of life if the pacifier was introduced in the first week of life. But it was no different if the pacifier was introduced after 3 to 4 weeks of life. So to be on the conservative side, what the recommendation has been is that if you're breastfeeding your baby, to wait 3 to 4 weeks until breastfeeding is well established and then introduce that pacifier at each sleep time, but to never force it on the baby and never put in any kind of sweet materials. When the baby starts to get teeth, that will promote cavities. So pacifiers are useful. You can promote your breastfeeding, you can promote pacifiers, and you can promote safe sleep. I now want to spend a moment talking about what some people call co-sleepers, or bedside or in-bed sleepers. And there are two types. The one is a bedside sleeper, which attaches to the side of the parent's bed. And we do have Consumer Product Safety Commission safety standards available for these that were just developed in the last couple of years. And then this other type is called an in-bed sleeper, which is actually put in the parent's bed. And we have no safety standards regarding these tools. So we don't have a recommendation for their use one way or the other because there are no published studies that have looked at an association between these sleepers and SIDS, or unintentional injury or death. So we don't say yay or nay. Part of the reason that we can't make recommendations about this is that these are newer products, and a lot of the studies that were done looking at the risk factors for SIDS and suffocation deaths are older studies before these products came out. Here's another product that's been developed in recent years that is found out in New Zealand and is used by their native Maori population. It's called the wahakura, and it's a woven flax basket that can be put in the parent's bed but provides a separate sleep surface for up to the first 6 months of life. And there's some early data coming out on this that seems to show some protective effect, but these families also get a lot of education, so we don't know if there's protection from the unit itself or from doing good education with the families. Another recommendation for promoting safe sleep is to avoid commercial devices that are not consistent with safe sleep recommendations. So you should be very wary of any products that make a claim to reduce the risk of SIDS. As a matter of fact, if a product makes a claim that it can prevent SIDS, you need to notify the FDA and the Consumer Product Safety Commission because those are false claims. So there's no harm in using devices, and some of these devices are special mattresses that are, some people say, breathable mattresses. They feel that if the baby were to turn over and end up face down, that it might be a safer surface. There's no evidence to that, but as long as the device that they're being used is consistent with Consumer Product Safety Commission recommendations and the ASTM standards for the product, there's no harm in using these special products. But again, they don't eliminate the need to continue to follow safe sleep recommendations. Okay, now some people look at using monitors at home, and there are these things called home apnea monitors. They do not reduce the risk of SIDS. These monitors can be of use when prescribed by a physician for a premature baby who is having a different problem called apnea prematurity, which is not related to SIDS. It's related to an immaturity in the baby's respiratory drive, and that problem goes away as the baby becomes more mature. And it's a tool that can be used to get babies home more quickly from the hospital when they're in the neonatal intensive care unit. But for the regular use in babies, it is not recommended. There's no evidence that these kind of monitors, after babies go from the hospital, that we cannot identify babies who are at increased risk of SIDS through the use of these monitors, and they're not recommended because they cannot prevent SIDS from happening. Okay. Now, if you're working with a family and you're going out to their home, there are certain things that you can look for. So we want to look for improper crib use, we want to look for those bumpers, and we want to look for those soft objects, other things that can be a threat to the baby's environment. And these images show multiple examples. If you go into a home and you see all the baby supplies are in the crib, if that family tells you they're using the crib for the baby to sleep, you know that there's probably some education that needs to be ongoing, because they wouldn't be storing all the supplies in there if they were putting the baby to sleep in that crib. And you want to look for unsafe cribs. So there are antiques out there that still have those wide slats that can be a risk for the baby slipping out and strangulating. This picture in the middle is a drop rail crib. Drop rail cribs went off the market in about 2013 because there were so many recalls and deaths related to them, either because they didn't function properly, they weren't put together properly. If we look at the picture on the right, the rail was put together upside down and it has detached, and the baby, from pressure against that rail, has slipped down, and now the rail has slapped back down against the baby, and now the baby is entrapped. And unfortunately, we've seen a number of deaths from this over the years, so we no longer have the drop rail cribs available for sale in this country. Okay, other things, look for signs of smoking, cigarette use in the home, because that really requires some education efforts. Secondhand smoke and even third-hand smoke, the smoke that's on your clothing. People hold their babies close to them all the time, and those babies are breathing in that third-hand smoke, and there are concerns about that in terms of SIDS risk as well. So we also want to make sure there are just general safety things that we're taking care of in the home, that there are smoke detectors, there are carbon monoxide detectors when needed, that we want to make sure the baby's crib is not too close to windows where there could be blind cords where the baby can get entrapped and strangle on those cords. And in the same token, if you're using mobiles, the mobiles need to be removed by the time the baby is 6 months of age and trying to get upright, so that if there's things hanging from that mobile, it's not something that they can get caught on to create a strangulation risk. Now, sometimes there are issues with people not wanting to follow the recommendations that we've put out there. So people ask, how do we deal with parents who are not wanting to be compliant with the recommendations? Either they want a bed share, use the bumper pads, or soft surfaces and such. So the question comes up, can we meet parents where they are? So let's talk a couple of minutes about this. It really gets us to focus in on how do we develop behavior change. I think at the end of the day, parents really want to do what's best for their babies. That's their job, as being good parents. But they may not have the information that they need, or they may not understand why certain recommendations are there. So if you're going to work with families, I think a good theoretical underpinning for understanding behavior change is this one on the slide here, the trans-theoretical stages of change model. So when we look at this model, some people are just not even aware of the recommendations. And so we need to provide knowledge to them, because at that point, they're what we call pre-contemplative. They don't even know if they need to make a change in what they're doing for their baby. Once they achieve that knowledge, we can have some discussion and consider a persuasion and change of opinion, get them to contemplate what's going on. And then if you get a positive result from that, then somebody will make a decision to make that change, and we can help them with making that preparation for the change. And then when they do, they actually implement it, and that's their action step of actually performing that change in behavior. And then you look at the outcomes of that. And if it's a good outcome that you feel is useful and keeps your baby safer, then you maintain that behavior and it keeps going on. But you can see from this graphic at any point that can be relapsed back into the old behaviors. So I think it's a good frame of reference for how we do our education with families. I think you need to know your audience. So you have to be culturally competent and know what the barriers are with the people that you're working with. So in a particular culture, what are their norms? What are their expectations? You know, one thing that people really have a misexpectation about is what's a good sleeper. Okay, that's one thing that people always ask new parents, how's the baby sleeping? Is he a good sleeper? And the truth is, a good sleeper for a baby who's only a month or two old is a baby that wakes up 2 or 3 times during the night. They're really not supposed to sleep 8 or 12 hours straight through the night. That's not what they're geared to do. They need to wake up. They need to have feedings during the night. They don't want to get in too deep of a sleep where they have those problems with arousal from sleep. So a good sleeper wakes up routinely. It's a different sleep pattern than what we do as adults. We also want to look at barriers. Some cases, the caregiver knows what the message is, but they're not changing their behavior, and the question is why? And it turns out that sometimes they want to have a reason. They want an explanation. Why do I need to do this? What is it about this recommendation that's good for me and my baby? And part of this is about gaining trust. So behavior change requires two-way communication. And anybody who has teenagers knows that if you just dictate and try to tell people what to do, you're going to get resistance and kickback to that. It's kind of like the old Charlie Brown commercials, and the teacher starts talking and it's just wah, 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 in one ear, out the other. So people want to have conversations. They don't want to be told what to do. Okay? And we also need to address sleep deprivation. I think a lot of parents, they start out with good intentions, but when parents get really sleep deprived, there's a potential to make poor judgments. And I don't think we as healthcare providers do a good enough job giving parents tools to put in the toolbox to cope with fussy babies. And this is not the purpose of our talk today, but just to quickly mention, there are tools out there that you can read about and work with. I like the 5 S's, which is swaddling, side carrying, shushing or white noise, swinging, and sucking. And when you do these things in combination, it really goes a long way towards calming fussy babies down. I think when babies are fussing and fussing and fussing, people can get into bad decision making, and that might be shaking their baby and creating abusive head trauma situation, or they just decide, I know the baby will sleep better on the tummy, so I need to get some sleep, so I'm going to put the baby face down or put the baby in bed with me. And although they really don't want to put their baby at risk, we haven't given them tools to help their baby sleep and fuss less, and we can get into these kind of dangerous situations. So you need to know what the barriers are and how to work with them. And there are studies out there that have looked at this, and these are some of the things that parents are saying. Again, it goes back to the slides we talked early on, that prone position. People are just so afraid of their baby choking to death. They think if their baby coughs and gets red in the face that they're choking to death. And they're not. They need to understand, it's just like you or me. If we cough hard, we get red in the face, but we're clearing our airway. It's a protective mechanism. So we need to teach them about not to be afraid of their baby coughing. The idea that babies sleep better on their stomach, and what's the norm for what babies are supposed to be doing when they're sleeping, as we just discussed. That soft things are safer for the baby, that babies are fragile and that they can't have hard things around them, that they translate their own idea of wanting a soft mattress as to the baby wanting a soft mattress, and that's not the case. For some people, they just say, hey, you can't tell me what causes SIDS. So SIDS is God's will. Why should I even bother trying to do anything? But even if we can't prevent everything, we certainly can reduce the risk. And one of the tools that I use with that kind of conversation is, well, if we can't talk about SIDS because we don't know what causes SIDS, we can talk about suffocation. So you understand that if a baby's face gets stuck in a pillow, they can suffocate. So let's talk about what we can do to make sure your baby doesn't get into a face full of bedding or a pillow and suffocate. Some people say, why bother? The recommendations keep changing anyway. And although the recommendations evolve over time, there's a good reason for that, right? Nobody writes with a typewriter anymore. Okay, nobody listens to music on a record player or even a CD player. Things change over time. As we get better information, we want to share the best information with families. So recommendations do evolve over time, and that's for the better. And then some people are doing things that are really dangerous, thinking that they're doing something that's going to protect their baby, like sleeping with their baby because they're afraid of rat bites or bug bites or stray gunfire. So it's very important that you make use of your assets. Again, a picture really is worth 1,000 words. So use the images, some of which we've shown through this webinar today and are available in many places that you can make use when you're working with your clients. Remember that all politics are local. Know your numbers. Use your evidence-based medicine. Most people think it can't happen to me. It happens to the other guy. Share real local stories. So people say, well, I can sleep with my baby because babies only die when you sleep with them if you're drunk or on drugs. And if you've had a story of somebody who's died from sleeping with their baby unexpectedly, you can share that story. I share a story. It's a relatively national story. And it just shows you that this can happen to anybody. And this doctor has become a good friend of mine over the years because we both share a passion for educating about safe sleep. His name is Sam Hankey. When he was in his pediatric cardiology training as a fellow, he had just had the birth of his first child, a son, Charlie. And Charlie was about a month old when one day Dr. Hankey came home from work. It was before dinner, I believe, and he just wanted to take a quick nap on the couch with his son. And his wife, Maura, who is a a school teacher, a teacher for young children. She says very bluntly that Sam woke up from the nap and Charlie didn't. And Charlie died of a SID, suffocation, death in the couch. And it just, this story goes to show you that if it can happen to a pediatrician, it can happen to anybody. To honor Charlie's life and his loss, the Henke started a foundation called Charlie's Kids, and there's a book that I think is a wonderful book that educates about safe sleep that I encourage parents to use. You know, people throw out safe sleep brochures, but you don't throw out your books, right? So that's something that we use at our hospital, and we give it out to every family before they take their baby home from the hospital, so it's their baby's first book. So just a small short story that I share with you. Again, make use of your pictures like we've already talked about here, so that parents can see the relationship of the anatomy, how gravity works. They can understand where things go when a baby spits up. Okay, here's another tool that I like to use. So people say, I sleep with my baby because I'm afraid of the baby getting hit by a stray gunfire. So here's some data from the CDC looking at gunshot wounds and the age of people when this happens. And we look all the way to the left. Under a year of age, it's almost none. I think for the year I looked at, there were 6 gunshot wounds to children under a year of age. Now, when you're 15 to 24 and 25 to 34, there are thousands of people being shot, and that's a real fear and concern. But when you're a newborn, you really don't need to worry about that. So what should you be worrying about? Why do babies die if they're healthy and they're past the month of age? Here's your answer. It's these sleep-related deaths, SIDS and suffocation. Compared to gunshot, that just doesn't happen. Now, if the numbers aren't enough to convince somebody that they don't need to be fearful of that, well, then let's talk about what you do in terms of rearranging your room, perhaps. Instead of sleeping with the baby, let's put the baby's crib away from the external wall where gunfire can come in, and then put your bed and sleep and your bed or whatever sleeping arrangement you have in front of the baby. So this way you can still protect your baby without sharing the sleep surface, so you don't have to risk a rollover death. Again, show these images, these reconstructions. These are taken from actual death scene investigations. So I think these images are very profound and can allow parents to understand how it can happen. We want to encourage parents to take action. Okay, if we look at social learning theory, parents are more likely to remember and comply with instructions when we as providers use a positive tone, provide adequate information, and we allow the parents to ask most of the questions. So we let them drive the conversations. Okay? Another technique that's similar, is very useful, and maybe you use this when you're dealing with families with alcohol and drug issues and even cigarette issues, is motivational interviewing, this collaborative, goal-oriented style of communication that pays particular attention to the language of change. And so, again, it's strengthening someone's personal motivation and commitment to achieve a goal and exploring the person's reasons for change and what those barriers are. And this is done in an atmosphere of acceptance and compassion. So some questions you can ask is, what's good about the baby's sleep behavior? What's not so good about the behavior? Look at a scale of importance. For some families, safe sleep is just not really high on their radar. So you want to know if things, the people want to get more sleep. So maybe sleeping with their baby, they'll say, it's important to me because I need to get sleep. And so if safe sleep's not important, you say, well, what will we need to make happen to make your score go higher in terms of the goals you want to achieve for your child? So this is a tool that allows patients to generate their own solutions. It makes it feel more realistic, and it plants the seeds of change. So even if you don't get the whole change at once, you can maybe do it incrementally. So although we don't really like the idea of risk reduction messaging, we'd like people to do everything the way that will maximize the safety for their baby, it may not be a reality. So there may be cases where you have to tell somebody this, they say to you, well, I'm not going to put the baby on the tummy, but I'm not really comfortable on the back yet, so I'm going to start out on the side. And so you say, well, look, that might be a little less risky, although side sleeping really is one of those things that's less risky. But we're talking about how do we minimize the danger. If you say the parent says, well, I'm still going to sleep with the baby. So maybe that conversation evolves from not getting the baby into a separate sleep surface, but maybe how many things can we get out of your sleep area that we know are risk factors? Or maybe that discussion is, Well, let's talk about the things that are in your bed. You don't want your baby to suffocate, so what are you going to do about your pillow? What are you going to do about that thick comforter you have? And maybe after they look at all the things that are in their bed, they say, wow, I don't know how to get rid of all these things. Maybe the baby should be in a different environment. So whatever you do, though, if you're doing risk reduction, you just need to document it carefully, that the family didn't agree to the recommendation but was willing to do whatever it is that you've discussed. And in that regard, there shouldn't be any legal ramifications for you. The parents are making decisions, and they're decisions that you're not agreeing with, but you're trying to work with them to minimize risk. At the end of the day, it's all about having the conversation. So we have to, as healthcare providers and as providers working with families, we have to have open and frank and non-judgmental conversations with families about their sleep practices. And if we don't have those conversations and engage them, we're not going to be able to achieve our goals for making things safer. Now, at this point in the webinar, I'm going to turn things over to Dr. Kasika from the Department of Health, who's going to share with you some excellent tools that have been developed by the Department of Health for you to share with your clients, focusing on the ABCs of safe sleep, which stands for alone, on the back, in the crib.
Thank you, Dr. Goodstein. As a part of a national and statewide initiative, the Department of Health has been focusing on improving the understanding of infant safe sleep messages to reduce infant mortality. The department has been partnering with the New York State Office of Children and Family Services to develop resources to highlight the messages of the ABCs of safe sleep that you've heard about, where the baby sleeps alone on his or her back and in their crib. As you can see from the slide, we have developed multiple resources. We have developed posters, brochures, magnets, mirror clings, crib cards, and videos. These materials have been provided to all birthing hospitals in the state so that when a family goes home, they are provided with a brochure, a magnet, a mirror cling, and the crib card so that the messages of safe sleep are reinforced. And we also have made sure that these videos and crib cards, etc., are available for other organizations. We've provided them to WIC and also to community-based organizations. This is an example of the Safe Sleep brochure. And this brochure is available in the 7 most common languages spoken in New York State. It, of course, includes English and Spanish. It's available in Chinese, Korean, Russian, Italian, and Haitian Creole. These resources are available on the New York State Department of Health website for printing. They're also available in our distribution warehouse so that you can order a hard copy of these materials, and this is free of charge. We've included the links here for the order form and also the website if you want to look at the materials and print them yourselves. We also have a Safe Sleep video that we have developed. It's a 1-minute video. It's available on YouTube, and it's available in English and also in Spanish. We are also working on placing the video on a DVD and a CD so that it can be used in educational efforts when you're speaking one-on-one with a mom or dad or a family. If you have further questions about safe sleep in general or any of the materials that are mentioned today, here is our contact information. And there's also an email on here so that we can get back to you with any question that you have. So I am going to turn it over for concluding comments from Dr. Goodstein.
Thank you, Dr. Kasika. So I just want to offer you this one last thought as we're closing out this session. You remember at the beginning of the session, we talked about the numbers in New York State, 132 children dying every year. That's the equivalent of 5 to 6 empty kindergarten classrooms that have been silenced forever. And so as you're working with your families, please, please, please remember that parents should be going to visit their children at the play yard, and not have to go to the graveyard. So I want to thank you for your time and for inviting me today. My contact information is here. If you're an extraterrestrial, you can use the link on the left. I prefer you don't use the soccer ball, but you can always contact me by computer like those smart little babies are doing. So that's all that I have for you. There are a couple of review articles that you can use to get more information about safe sleep. And I don't know, Dr. Kasika, do we have time for a couple of questions?
We do, and we've had several questions asked by a lot of people that I think it would be very good to discuss. So the first question is, what do you do with an infant when they begin to roll on their stomachs?
Oh, that is a great question, because they are eventually going to do that after 2, 3, or 4 months of life. So when babies can roll front to back and back to front, it's okay to let them roll into the position that they feel comfortable with for their sleep. However, when babies are put down for sleep, even if they're going to have a preference for being on their tummy, they should always be put down on their back for sleep. So we don't want parents going crazy every 5 minutes seeing their baby flip over and flipping them back again, because then the baby's going to be upset, the parent's going to be upset, nobody's going to be happy, and that's not a good situation. So babies can roll and do what they want to do once they're mature enough to do that, but parents should always put them down on their back to sleep for every sleep time until the first birthday.
Great. Is it safe for a baby to sleep with a hat on?
It's not recommended. I mean, basically, in the first day of life, when babies are first born in the hospital, they do have some transitional issues with trying to stay warm, and sometimes they do need a hat for that. But they get acclimated very quickly, and after that, they don't need the hat. So hats are important when you're going outside. If there's a cold environment and the baby is awake and being monitored, you can have hats on. But when a baby is sleeping, they really shouldn't have that hat on. It could slip down over the nose and mouth and create a hazard. So there's really no reason for that.
Now, is it safe for a baby to sleep in his or her car seat?
Well, that's another really good question. And the answer to that is a little nuanced. So the answer is typically no. However, babies are in car seats while you're driving for a reason, to keep them safe while you're in a moving vehicle. So if a baby falls asleep while they're in the car seat, you don't need to wake them up. But when babies are moved from the car, the moving vehicle, back to the home or wherever it is that you're going to, then as soon as you get to a place where a baby can be transitioned to a safe sleep environment, they should be moved out of the car seat. A lot of people, when they get somewhere, they don't want to wake up the baby, but the car seat is a dangerous place for long periods of sleep, and there are studies that have looked at that. And sometimes what's really dangerous is that people will want to make the baby more comfortable by unbuckling the car seat and then leaving the baby in there. And babies have gotten the car seat buckles and straps entangled around their necks, and they've strangled on the car seat. They've gotten tipped over the top and gotten their necks caught on the top of the car seat. There's all kinds of mechanisms with a baby squirming and moving around where they can get into trouble with that. So babies, even when you're driving, babies should get out of that car seat every 1 or 2 hours, and people in general should get out of their cars briefly to kind of stretch the legs and get the circulation going. But it's important. We don't know exactly how long you need to go between stretches, but every so often you should get that baby out and just kind of get things circulating out of that car seat again. And again, when they're in the home, they shouldn't be sleeping in that car seat. It's on an incline. It can worsen reflux. If the baby leans forward, it can compromise their breathing. So lots of dangers to doing that.
Great. Well, I want to thank you, Dr. Goodstein, for all this great information that you included in your presentation. I think it's going to be very helpful for a lot of people. And thank you for joining us today on the behalf of OASAS and the Department of Health.
I want to thank our presenters today. This was a process that was a long time in the making, and it was definitely worth the wait. It's a conversation we don't have, and the information is something that most people are not aware of. So again, thank you for bringing this informative presentation to the Learning Thursdays educational series. Folks, as I've noted earlier, if you have any questions, send them to learningthurs@oasas.ny.gov. Folks, we welcome your feedback. It lets us know if we are meeting the educational goals and the expectations of the field. Once you have viewed the presentation in its entirety, Please follow steps 1, 2, and 3 to access SurveyMonkey link. Again, that being said, thank you all for joining us, and we will see you in June. Bye now.